So it's a great pleasure now to discuss with you endocrine diseases in Carney Complex. You probably know this paper that is the first description of what we call now Carney Complex. This paper is now 40-year-old, but you have to realize that 40 years to describe a disease, that's quite recent, in fact. And when Dr. Carney was, as you probably all know, a pathologist at the Mayo Clinic, described the disease and identified the disease. It started by the description of 4 patients from the Mayo Clinic that were reported 1 year before this paper as presenting a very unique cause of Cushing syndrome, so of cortisol excess, that he called primary pigmented nodular adrenocortical disease, or PPNAD. And later on, he realized that these patients are similar cases in the literature or similar cases in the Mayo Clinic archive presented other manifestation. And he had the very smart idea to make the hypothesis that there was a link between PPNAD and this other manifestation. And among this manifestation, he noticed spotty brown-black pigmentation of the screen that we know now as periofficial lanthigenosis, so small pigmented spot around the eyes and around the lips, and myxomas, and especially myxoma that are located in the heart, so cardiac myxoma. And the 3 entities that he grouped around this term complex of myxoma, spotty pigmentation, and endocrine overactivity is what we call now Carney Complex, after him. And I'm going to describe today the endocrine aspect, so what he called at that time endocrine overactivity. Just to illustrate this quite unique cause of Cushing syndrome, PPNAD. And you can easily understand that as a pathologist, Dr. Carney was very intrigued by this aspect. These are 2 adrenals removed from patients from our center, patients suffering from Cushing syndrome due to PPNAD. These 2 adrenals, they have a normal size and normal weight, but what's unique is these small nodules that are highly pigmented. You can see they are less than 1 centimeter. You have here the scale. And this is quite unique if you look at the aspect of other cause of Cushing, for instance, adrenal cancer or adrenal adenoma, or another form of bilateral nodules that we call primary bilateral macronodular adrenocortical hyperplasia, where the nodules are much larger, more than 1 centimeter. And we realized recently that this is also a genetic disease, but it's diagnosed in adults, usually between the age of 50 to 60. Nothing in relation with PPNAD that we are going to discuss today. The gene of Carney, as you all know, has been identified by my friend and colleague, Dr. Stratakis, now 25 years ago, and with his postdoc, Dr. Larry Kirchner. And we were very interested to realize that the gene that Stratakis identified was sitting in the PKA cyclic AMP signaling pathway. As you all know, this is the regulatory subunit A1A of the protein kinase A enzyme. And this signaling pathway plays a key role in various endocrine cells, especially, for instance, the adrenal cortex, where pituitary ACTH stimulates cyclic AMP and then PK signaling. And the genetic defect that causes Carney complex activates the PK, so mimics somehow the effect of the stimulation of the pathway. And we know that there are several endocrine glands where the signaling pathway is key for development, for maintenance, and for hormonal regulation, hormonal secretion. And this is, for example, the case in the pituitary for the growth hormone cell, the case for the thyroid cell that are stimulated by TSH, the case, as I already described, for the adrenal cortex stimulated by ACTH, and the case for the gonads, so ovaries and testes that are stimulated by FSH and LH, that in turn will secrete estradiol and testosterone, as the adrenal cortex will secrete cortisol, as the thyroid will secrete thyroid hormones, and as the pituitary, after stimulation by GHRH, that stimulates PK, will secrete growth hormone. Yeah, three different series of patients that have been reported in the literature that I take an example just to describe the various manifestations of Carney complex. And you probably are all aware of these studies. The first one is the initial description by Dr. Carney, 40 patients. The second one is a study that we done in collaboration with Dr. Carney and Konstantin Stratakis, is the retrospective analysis of a large series of patients with Carney that have been genotyped at the NIH or later on in our Center for European Patients in Cushing Hospital. And the last one is a more recent prospective study that we've done at the national level, where we've followed for 3 years, once a year, the patients that were enrolled for all the manifestation of Carney. And in red here are pointed the endocrine manifestation: PPNAD, thyroid tumor, acromegaly, so growth hormone secreting adenomas, ovarian lesion, and testicular tumors. We're going to describe these various manifestations. By PPNAD Cushing syndrome, the main manifestation that led to the description of Carney complex. Just few words about the adrenal for the one that would be less familiar with this endocrine gland. This is a very small gland localized above the kidney. You can see it on the CT scan. And you can see this gland after removal by the surgeon and removal of the fat by the pathologist, because the gland is surrounded by fat, as you can see here. And when the pathologist cut this gland, you would see that there are two different zones, one in the center that we call the medulla, that is not altered in Carney complex, and one surrounding it, a little bit yellow, because it's lipid rich, that is the adrenal cortex. The adrenal cortex means cortisol, aldosterone, and the androgen DHEA. And this is the adrenal cortex that is altered in PPNAD, and pigmented nodules arise from the adrenal cortex, and they over-secrete cortisol. The other hormones are not altered in most patients with PPNAD. The adrenal cortex is controlled by the pituitary hormone ACTH, and the cortisol, when stimulated by ACTH, would in turn inhibit the pituitary axis to avoid too much cortisol to be secreted. In the normal subjects, when the corticotropic axis works fine, there is a circadian rhythm where cortisol level will be high in the morning and low in the night. In Cushing, regardless of the cause, PPNAD or other causes of Cushing syndrome, because PPNAD is one of the various causes of Cushing syndrome, there is a loss of the circadian rhythm. So in the night, the cortisol remains as high as it in the day. And we know that the cortisol acts on various tissues because the receptor of the cortisol, the glucocorticoid receptor, is quite ubiquitous. So it acts on the adipose tissue, on the bone, on the liver, on the muscles, on the pancreas, on the brain, on the leukocytes. So it has ubiquitous action. So you can easily understand that when a patient suffers by an overproduction of cortisol excess, in the most severe cases, it might present many manifestations: thymic disorder, vascular and heart disease, hypertension and diabetes, increase in body weight, myopathy, sensitivity to infection, osteoporosis, and so on. Because PPNAD, as we will see later, is diagnosed mostly in children and young adults, it's quite often that it could be observed in a child. And cortisol excess in a child will alter growth. And you have here one example to illustrate that. These are two twin sisters. One, as you can guess, the upper one, suffer from Cushing syndrome. This is not PPNAD. This is another cause of Cushing, but the consequences are the same. It's Cushing disease. After treatment, and in this case, this is pituitary surgery, bone densitometry improved, and as you can see, she recovered a normal appearance as a twin sister. But if you look at the whole body picture of them, they are 10-year-old here. When they are 15-year-old, you can see that the one who had suffered from Cushing, because during the Cushing, before the diagnosis and the treatment, she stopped to grow, then she didn't really recover at the end. So even though she's fine, apparently, and doesn't suffer anymore from manifestation of the Cushing, there is a sequela at the level of the bone. The fact that the growth failure before the treatment was not able to catch up. And this is one thing to keep in mind, that with Cushing syndrome, the younger the patient, the most favorable usually is the outcome after cure, because patients are going to recover from hypertension, diabetes, body weight increase, much better if they are younger than older. But there's one thing that cannot catch up in all the patients when the consequences of cortisol excess on growth have been too severe. This is the final height. So this is one thing to keep in mind where we are going to discuss later on treatment of Cushing. I won't recommend the same attitude in a child with a severe growth failure than in an adult with just only body weight increase and hypertension, for instance. The age at diagnosis. So this large cohort that we analyze in a retrospective way with Dr. Carney that you see here, my friend Konstantin Stratakis, and this is a picture that was taken in the Azores, so an island in between Europe and the USA, that this smart Portuguese endocrinologist thought very appropriate to organize a meeting on Carney Complex, and we met there with him, a family that he take care of in the island with Carney Complex. And this was a very nice occasion to discuss with Dr. Carney and Constantine about our cohort. And as you can see, the age at diagnosis, the youngest patients are around 4 to 5 year old. And after the age of 15 to 16, there is an increased prevalence of female. That's the age at diagnosis. And there is an overall female prevalence where you will have 2.4 female for 1 male. And this is occurring after puberty, leading to the speculation, but we don't have yet full proof of that sex steroid might play a role in the development of the disease. Just to illustrate the situation, here is the main fact about Cushing syndrome in the first 5 patients that we diagnosed when the gene was identified by Konstantin Stratakis as having a Carney complex gene mutation and no other manifestation of Carney than PPNAD. And you can see most of them are female. There's 1 male out of the 5. The age at the first reported symptom varies between 5 and 27-year-old, but the age at diagnosis in most cases is much later. There is clearly a diagnostic delay. This can be explained by many different hypotheses, but one is that in this patient, 3 out of 5 of these patients presented with cyclic hypercortisolism. And it means that there are periods where they made too much cortisol, and then it's normalized. And the time to have the appointment with the endocrinologist, if someone would speculate about Cushing, might be long enough that when they see the patients, there is not anymore an active Cushing syndrome, and the biological investigation are normal. But usually it comes back later, and after some time, some months or some years, depending on the patient, it's constant. And then the diagnosis is made. So this is one first explanation. The other, of course, is that as for a lot of rare disease, the physicians are not always aware, so they are not thinking about the diagnosis. But things are improving with time, I think, at least the last 20 years. And also with the help of internet, I would say, because patients more and more now are themselves thinking about the possibility of Cushing. As you can see, where the diagnosis was made, they all have very high urinary free cortisol level, especially the one that were young kids. This is unusual to have such high level when you are 10-year old. And they all had, at the time of the diagnosis, a complete loss of the circadian rhythm because the plasma cortisol in the morning and evening were clearly the same. Acetate is completely suppressed because cortisol exerts a negative feedback on the pituitary. And as you can see, one presents an adrenal nodules, but the other one presents a normal CT scan. This is another explanation why the diagnosis sometimes in people that are not aware of the disease is difficult to make, because you have biological proof of adrenal Cushing, but no adrenal tumors. And if you don't think about PPNAD, where the nodule can be so small that you don't see them on the CT scan, you might not think about the possibility of the diagnosis. Here's one example of the cyclic aspect of cortisol excess in an 11-year-old girl that collected salivary to assay cortisol every day, 17 consecutive days, in the morning and in the evening. As you can see, it's high in the first 8 to 9 days, and then it's the normal range for the morning cortisol. But what's still abnormal is that the night cortisol is at the same level than the morning cortisol, or it should be much lower than the morning cortisol. So it's cyclic, but if you look carefully, there are stigmata of cortisol dysregulation in these patients. As I say, the CT scan can look normal or almost normal, so if you don't know this disease, you might miss it. And how often PPNAD is observed in Carney Complex. Here is the results of our prospective study in France, where before inclusion, 40% of the patients were already diagnosed with PPNAD, and at the end of the 3-year follow-up, that's 57%, with overt Cushing that deserve treatment. What we observe in this cohort is that with systematic screening, patients might present abnormalities of cortisol, especially an abnormal dexamethasone suppression test, while they don't have yet clinical signs of Cushing, and their urinary and midnight cortisol might be still normal. So they have cortisol dysregulation, but not bona fide Cushing syndrome, or maybe not yet bona fide Cushing syndrome. So we monitor them carefully, and some of them with time, 2 or 3 years later, developed overt Cushing and then started to be treated. So PPNAD is clearly one of the most frequent manifestations of Carney Complex and one of the and clearly the most frequent endocrine manifestation of Carney Complex. The Carney Complex gene, we know now that there are some mutations that predisposed mostly to PPNAD, and the patient do not present the other manifestation of the disease. This is the case for this specific mutation here, that is a small deletion in an intron of the gene that is highly prevalent in France. We reported it for the first time, that's a little bit less than 20 years ago. And in collaboration with Constantine, he was able also to identify the family that were referred to him from Spain, another one that was from North America. But other family at that time were from France. And since that time, we increased the number of index cases, so families in France to 15, and we have 51 patients. And studying these cohorts, this is not yet published, but we know that they present PPNAD and no cardiac myxoma, no pituitary adenomas, no schwannomas, and no breast myxomas. So this is one of the rare Carney complex mutation that predispose mostly to PPNAD and not the other manifestation of the disease. And why is it so prevalent in France? This is because we think that there is a founder effect in the north of the country, even though each family has a different family names. And so if there is a common ancestor, it's more than 300 to 400 years ago. But most of the patients, they come from the north of the country. And we have now families that are referred from the French-speaking part of Belgium. So the country that is just at the north border of France, so close to the French families that we identify. There is another gene that can cause only PPNAD. This is the catalytic subunit of PK. This is much more rare than a mutation of the Carney complex gene. This is not a mutation, but a duplication of the gene. We have identified now 15 patients from 7 families in France and a few of them also from Brazil. And studying here again the phenotype, they don't present these other tumors. They might present testicular tumor, ovarian lesion, thyroid tumor, and lentigginosis, but not the other one. So this is important for patient information and, of course, monitoring. So in conclusion about PPNAD, bilateral pigmented micronodules that are smaller than 1 centimeter. The diagnosis is usually between the age of 5 to 40. It's more rare later. It's very rare before 5, but it can happen. It can be cyclic. It can be initially, and this is clearly what we see with familial screening, without clear clinical signs of Cushing. But at the time of diagnosis, in the case where you are not in the situation of a familial screening, there are usually clear clinical signs of Cushing with a major biological alteration, as you saw on the series of 5 patients I mentioned earlier. CT scan can be normal or can demonstrate micronodules that the clinician is not always sure that this corresponds to PPNAD, because when it's small, it's difficult to be confident about that. The treatment, so the classic treatment is bilateral surgery. Some patients have been treated with unilateral adrenalectomy with good success, but they are, I would say, the exception. We have limited experience with anticortisolic drug. We start to do it mostly with the patient with no clinical signs that are identified by familial screening. It's worked well, but we don't know yet if it will work for lifelong and if it will be enough. And I would recommend that only in patients with minor clinical manifestation and not in a case with a dramatic growth failure, because you might then lose the opportunity to catch up with the growth by a potent treatment. Today, the genetic cause of Carney can be identified in more than 80% of the patients, and even in a patient with isolated PPNAD, combining A1A sequencing and search for C-alpha duplication. It's more than 60% of the patients with isolated PPNAD that can present with a genetic explanation. Let's discuss now the pituitary manifestation of Carney, pituitary adenoma and acromegaly. So the pituitary gland is depicted here, and it's made of the posterior lobe and the anterior lobe. What's altered in Carney complex, or can be altered in Carney complex, is the anterior lobe. The anterior lobe contains various cells, the cells that make ACTH, FSH and LH, TSH, growth hormone, and prolactin. The one that can be altered in Carney are the growth hormone, and in a subset of patients, the prolactin secreting cells. Growth hormones when secreted by the pituitary in the general circulation, stimulate at the level of the liver the production of IGF-1 and act as well as IGF-1 on various tissue like the bone, the muscle, and earth. Of course, the main effect of growth hormone in physiology is to stimulate growth in children, but it has many other effects both in children and adults, considering the fact that there are many tissues that express both the growth hormone and the IGF-1 receptor. Excess of growth hormone can lead to many manifestations, and this is what we call acromegaly. Acromegaly means in Greek large extremities, large hands, large feet, because that's the effect on the soft tissue of the growth hormone that increase the volume. It leads also to change in the facial appearance with facial deformation, increased volume of the heart, of liver. It's a cause of hypertension and also a cause of diabetes, like cortisol excess. Prolactin acts physiologically on the mammary gland to stimulate milk production. When prolactin is too high, it can inhibit also the gonadal cells. So it inhibits FSH and LH. It decreased the activities of the ovaries and the testes. It can cause galactorrhea, so that means milk production. Gynecomastia, that means breast enlargement in male, and it can, of course, decrease both estrogen and testosterone in girls and boys, male and female respectively, causing hypogonadism, irregular cycle, and amenorrhea. Acromegaly is diagnosed in Carney, as you can see from the large cohort that we have investigated with Dr. Carney and Konstantin Stratakis. Usually in young adults, it's very rare in children. By our systematic screening in our prospective study, we observed that 9% of the patients was diagnosed with acromegaly before inclusion in the study. And at the end, because they all had systematic screening with growth hormone energy for an assays, that was 90% of the patients. And as for cortisol, there is a subset of patients with alteration of growth hormone of IGF-1 that do not match the diagnostic criteria of acromegaly, but that suggests that there is some level of hyperactivity of the axis, even though they don't have bona fide acromegaly. And that's observed in a third of the patients. It's quite significant. And this is scored that's only 2 patients that present with increased prolactin. So increased growth hormone is more frequent than increased prolactin. What's happening in Carney Complex pituitary is an hyperplasia or some small adenomas, as you can see here in this patient that were published from the NIH neurosurgeon with various small microadenoma. And sometimes you can have a large adenoma. So in conclusion, there's 12 to 20% of the Carney complex patients that develop a classic acromegaly that deserve treatment, usually after the age of 20. Patients with pituitary hyperplasia are not going to be cured by surgery. Patients with microadenoma maybe, but it really depends on the number of the morphological presentation. And there are rare patients with microadenoma that will deserve surgery. So at the end of the day, probably we treat less by surgery acromegaly in Carney complex patient than in other type of patient with acromegaly. They do medical treatment, which is somatostatin analog and growth hormone receptor antagonist. And there is a subset of patients with somatostatin axis dysregulation, some level of hyperactivity that is, from the clinical point of view today, the significance of that is not known. We might speculate that this might play a role also on the development of some other manifestation of Carney, so this is something to keep in mind. Let's discuss now thyroid nodules. So usually, despite the fact that cyclic AMP stimulate production of thyroid hormones, the thyroid hormone level are normal in Carney complex patients. I have few patients with excess of thyroid hormone, but because this is not so rare in the general population, I'm not convinced that this is due to Carney. But thyroid nodules are most frequent in Carney complex in the general population. It's already quite frequent, as you know, in adults in the general population. It's more frequent in Carney. That's 11 to 35%, depending on the criteria. The more stringent the criteria would be in terms of size and of nodule, it'll be closer to 11. But if you are less stringent, it's about a third of the patients. And considering that they are young adults, this is more than the general population. In the old population, it would be not that different. What's clearly different than the general population is the frequency of thyroid cancer. This is 2% in Carney complex, which is somehow not very high, hopefully which is good, but this is more than general population. As you can see, thyroid tumor in Carney complex occur at an older age than the other manifestation. It's around 40-year-old. Let's discuss now to finish testicular and ovarian lesion. Let's start by the testes. The classic manifestation of Carney in the testes are large cell calcifying serous cell tumors. They are bilateral and multiple calcified tumors, as you can see on ultrasound. They are small. They are observed in a third to half of the patient, depending on the series. And they are not associated with hormonal alteration. So in the majority of the patients, we just monitor them. It's only if there is a growth of this calcified tumor that we are going to discuss biopsy or surgery. There is a small subset of patients that present a different type of tumor developed from the Leydig cell, the one that make testosterone, and they are secreting estrogen, so it can be a cause of gynecomastia. In our French cohort, that's a series of 26 patients that we have recently reviewed. Testosterone, FSH and LH level are normal except in one case. So these tumors, except the Leydig one that are more rare, are not associated with hormonal dysregulation. There's a question mark whether this calcified tumor might alter spermatogenesis, and there are indeed some case reports of infertility. It's difficult to know for sure. We have not done a systematic sperm analysis. And what we know from our cohort in France is that half of the adults had at least one children. One needed the in vitro fertilization because this is one of the cases with Leydig cell tumor that was operated on. So as a sequela, I needed in vitro fertilization. And for the other half, it's unclear whether they are infertile or just they didn't wanted so far to have children. So the message is that we are not sure whether clearly there is a sperm production alteration, but it should be mentioned and explained to you men so that probably they would have sperm analysis, and even if they don't want yet a child, it's probably safe to go to the sperm bank to store the sperm in case later on the production will be altered. What about the ovarian? So there are an increased frequency of ovarian cysts. There were discussions whether solid tumor might be more frequent and cancer. I remember having discussed that with Dr. Carney. He was not convinced. One thing that make difficult to claim that there is an increased frequency of tumors of the ovaries in Carney is that by difference with male, where clearly there is one specific type of tumor, these large cell calcifiing cell tumors. In female, the histology of the one that have been operated because they had solid tumor, this various histologic type, and the frequency and the fact that this is various type make that less likely that this is clearly linked to Carney. But this is good practice to monitor with ultrasound ovaries in Carney complex patients. You have to be aware that breast lesions are frequent. Most of them are benign, fibroadenoma and myxoma. They are sometimes difficult to diagnose if you are not well aware of the disease. And mammography, ultrasound, and especially MRI need to be carefully analyzed. And according to analysis that we have done in France, there is a slight increase of breast cancer in young Carney complex female patients, by comparison with the general population. It's already quite frequent in the general population, but slightly more frequent in Carney complex. The good news is that these are estrogen-positive receptor tumors of good prognosis. We have no case of fatality so far, and they have been all cured, even the one that were metastatic at the time of the diagnosis, probably due to the fact that they are positive for estrogen receptor. So what we advise in the country now is to start screening for breast cancer earlier than what we do in the general population. The population is usually around 50, and we recommend to start somewhere between 35 and 40 in Carney complex patients. So in conclusion, the most frequent endocrine manifestation of Carney is adrenal Cushing with PPNAD. It needs to be screened both with clinical examination and biological monitoring at least once a year, I would say. Then you have growth hormone dysregulation, that's biological monitoring. It's less frequent. It's usually not observed in children. And then you need also to be aware of the presence of thyroid nodules and a slight increased frequency of thyroid cancer. So you need to monitor with ultrasound. And if there is any doubt on the nodules, to do a cytofunction alteration for cytopathological examination, and to monitor the gonads with ultrasound, especially in male. I will thank you for your attention. I will thank my collaborator in our research team, in our clinical departments, and all our collaborators at the national level, the European level, and our long-term collaboration with Konstantin Stratakis at the NIH and now in Greece. Thank you for your attention.